Hi, good afternoon. I'm Scott Swanson. I'm a thoracic surgeon at the Brigham and Women's Hospital, and I'll introduce our panel in a moment. We're going to have a discussion about minimally invasive lung surgery and highlight robotic and video-assisted approaches to minimally invasive lung surgery and discuss the differences in those techniques. So each of us will talk to each other on those topics. To my right, and left are the panel members. I've Bernie Park, who's from Memorial Sloan Kettering, Shanda Blackman, who's at the Mayo Clinic, and Rob Cerfolio, who's from Alabama. And we'll all discuss these topics this afternoon. Good afternoon.
Good afternoon.
Good to have you all here.
Thanks, man.
So I just came from a session that you may have been at, the lung cancer session, and there was a paper that just was presented by the group, I think one of your old New York, well, I guess he was at Cornell, Rob Kort's group, who's now in New Jersey, comparing robotics and VATS. And it came up with a lot of the same ideas that we've seen before, which is that they're fairly similar with some differences in time and cost and that kind of thing. So maybe the first question is, what do you all think about the differences between VATS and robotics? What are they? And
So I think, that several differences are to get going, to get started. With robotics, there's a little more ports placement. It takes a little longer to get going. There's clearly higher capital cost. I mean, people don't talk about the cost of all the monitors with VATS, but even if you put those together, it's less than a robot. And then there's the yearly fee for the robot. And so there's a higher capital cost. And then the cost per case is a little bit higher if you look at the instruments. So what do you get for that? Is there a benefit from that? I think it depends on the surgeon's experience, his practice, and the patient. I think more patients probably, for most surgeons, could get a robotic lobectomy than can a VATS. You can maybe do some bigger tumors with it. Maybe you can do some plastered N1 lymph nodes, but in very skilled VATS surgeon's hand, that difference becomes less and less and less. I think it's probably an easier transition if you're an open surgeon and you know that minimally invasive is unequivocally all of our future, and you've struggled with VATS. It's a nice venue to become a minimally invasive surgeon because I think it's an easier transition. So I think there's pluses and minuses.
Shanda, what do you think?
I personally think that the robot is a great enabling tool, and I enjoy doing robotic surgery. That being said, for lung work, I feel a lot more comfortable doing VATS because I have the tactile feedback. If I'm putting stress on a vessel, I tend to be better at judging that stress on the pulmonary artery in a VATS than I am on robot right now. You have the visual cues on robot that you learn to help you to recognize when you're putting tension on something, but you also lose that tactile feedback. So I feel like I can do any surgery with VATS, and robot doesn't allow me to do a surgery that I cannot do on VATS. And given that it adds cost, I've had some concerns. For other cases, like thymic work and esophageal cases, I think I would prefer robot in some of those cases. So just for looking at lung alone, because of the cost issues, I do have some reservations of going to VATS, but going to robot. But I think we need to stay in the game, and we need to keep playing with those instruments, because I think there may come a day where the robot might be even more of an enabling tool that helps us become better than VATS. And when that happens, you need to be facile with the robot.
Bernie, what do you think?
Yeah, as somebody who's done both techniques for a number of years, I agree with everything that's been said. I think that the robot really provides a superior level of technology, but whether that level of technology is required in all cases or more complex cases is it's really difficult to ascertain. I think that if you compare master surgeons in either technique, you're not going to see a lot of difference. And I've always maintained that robotic surgery is really VATS surgery, but with sort of the highest iteration of technology. And whether that extra cost and that extra effort is responsible or required, it's a matter of great debate. I do think that anybody that's done both techniques, probably from the surgeon standpoint, feels that there are great benefits, but that can't really be demonstrated in objective data. And I think that's really the difficulty there. But I do think that in my hands, at least, I do feel that robotics allows me to extend indications for certain operations, allows me to do some more complex things. And I think the tactile, the binocular vision, which I think some VATS technologies are now trying to replicate that. There's obviously a reason for that ability to replicate your two eyes in the chest is important. But I do think it's absolutely requires us to be very thoughtful about what are the most appropriate instances to use robotics. Because I think if our real mission, and maybe something we need to talk about, is whether robotics can allow us to, we still do too many open surgeries as thoracic surgeons throughout the world, and we need to transition from not so much thoracotomy to robot, but thoracotomy to minimally invasive. And whether that's robot or whether that's VATS, if the robotic platform can help us get there, I think there's value in that.
And you mentioned around the world, and there's countries that can't afford the robot. I mean, as I mentioned, I'm going to India in a few days, 1.2 billion people, 22 robots. And so for them to teach them a minimally invasive platform they can't afford doesn't make sense. And, you know, a VATS platform.
You could argue, can we afford it?
Sure.
You know, we're already, you know, spending a lot of money on medicine. And would it be more reasonable to advance a simpler technique more widespread, or try to advance a more higher technology technique? I don't know the answer, but I do worry that access and cost will be limiting as we go forward.
And I think those are great points. I think as more robotic systems come out, the cost is going to come down. I still think our future is computers and robots to do surgery. And I think if we're not in the game, then we're going to be out of the game, like stereotactic radiosurgery, which is a fancy robotic computerized system. So I think it's up to us to be in it, as we all said, and drive costs down. I think that if you can show outcomes benefit, which we're trying to show at University of Alabama, Birmingham, with the robot, that makes sense for the added cost, then it makes sense. But it depends on who you are and what you're comparing it to. And every study like the one we saw today is limited by the comparison group. And you know, if you're a great VATS surgeon and you do great lymph node dissections, your VAT's going to look good. And if you're a great robotic surgeon, you do a great lymph node resection, your robot's going to look good. And that's where the data's flawed.
And I think that's true with all series. I mean, we published that meta-analysis that used the SEER or the one of the databases that was kind of a real-world database, and showed no difference in morbidity, mortality. The only difference were time and cost, to the tune of about $5,000. Now, it highlighted the southeast part of the country in the robotic side, because that at the time was where most of the robotics was being done, and that's where the database was. So I think we picked up a couple good surgeons in that side.
I'm sure you did. I'm sure you did.
I
Picked
think
up
it
me and
was
Toulouse.
reasonable. So I think we're all seeing, I mean, I think we'd all agree that the outcomes for surgeons that know what they're doing are similar, and that the nodal differences, I think today showed no difference in the study, and I think it's more how interested you are in doing it.
Right.
So that is unclear, but they do seem similar. So the question is, if we're really trying to disseminate the technique, does anybody have any insight about, you know, in the next 5 years, where we should focus? Should we focus on teaching surgeons robotics? And then where I really would like to hear about what you think is there a certain number you need to do per year to be facile?
Yeah.
In other words, the average lobectomy surgeon is doing 10 a year. Or 5 a year. Is that enough to be good on the robot? I know VATS-wise, that's kind of right on the edge. I don't know about robotics.
Yeah.
I think they're similar. I think that's a much broader question about centralization of care, and so I think we should focus more on teaching surgeons anatomy, teaching them how to respond when minimally invasive bleeding and have a planned response. I think that's much more important than the debate of robot versus VATS. We should be minimally invasive surgeons because that data is clear.
So let's talk about that.
Yes.
What do you do? So how do you manage bleeding? That's something that scares everyone, minimally invasive. What's your approach?
So we practice a protocol once every 2 weeks, and it is everybody is calm in the room. You know, we don't type and screen or even type and cross the patient. So we have to get trauma blood, which takes 10 minutes, 10 to 12 minutes. So we just pack, and we just pack and pack and pack, and everybody is relaxed. And opening urgently is the biggest mistake in the world. So it's a calmness in the room. It's a pack. There's 2 little rolled up Ratex we have on the bedside that can come in quickly. Then we try to let go of the robot and make the packs, everything stops bleeding without pressure. And we go somewhere else and work somewhere else for 15, 20 minutes. By the time you come back, 95% of the time that injury is gone. You don't see it, and you can clip or control it robotically behind. So I think it's a prepared responsiveness that is the key to how you handle PA bleeding.
Something that we do that's a little bit different is I record every case that we do, so that if we have a bleeding event in the middle of a case, it's quite rare and it's hard to teach the residents what to do. So if you're not recording every case, you're never going to be able to go back and look at your black box and say, here's what happened, here's how we do it different. So we record every case, and if you do have an event, it's very thoughtful to bring it to our morbidity and mortality conference and do the Monday morning quarterback playback and show the residents and the team, and even the operating team comes to this meeting as well. So we not only rehearse what to do in a disaster, but we replay the events that we've already had, and we talk about how did we manage it and how would we do it different. And I think that creates just another level of safety.
Well, we do the same thing.
Yeah.
That's good.
You record everything. Even open cases can be recorded. In fact, soon, that record's going to be your operative dictation. Your operative dictation is going to go away and be
And you just
the
upload the
recorded
video.
video.
That'd be great.
Yeah, well, that's where we're headed.
I mean, we do a similar thing at Memorial Sloan Kettering. We have part of our timeout process is we discuss, okay, what is the contingency plan if there's an intraoperative event, so that we go over for every case, okay, if there's bleeding, let's make sure we have the sponge stick available. Do we know where there is another senior surgeon available if need be? Is there a type and screen, or are we using trauma blood? That kind of thing. I use I do use a utility incision because I like the safety of having the bedside assistant able to put in a sponge stick and compress. But all these principles I think are really important. I personally, one of the things I love about robotics also is that when I do my dissection, I really take out all of the hilar lymph nodes. So I had a case where we had caused a little tear in the superior segment branch, but because we had taken out all of the hilar nodes, we were able to put a little cross clamp on the basilar artery, control that. We could repair it. We repaired it robotically, take the cross clamp off. So it's kind of nice. I think it's just about anticipating, being prepared, having a plan of what to do, and you
Cross
can.
clamp went through the axis incision?
Yeah, we
Okay.
just put the cross clamp, and because I put one of my arms through the utility incision, there's plenty of room there. Then I could put that in, so I could see the defect. I could sew it and then take the cross clamp off, and it worked out well.
And
so.
that can be done with VATS just as well. Very
Yeah,
good
I've
VATS
seen
surgeons
some-
do that. Yeah.
I've seen some great video of you repairing I think it was a right middle lobe artery, and doing a VATS repair is completely a feasible option. I think the thing that worries me is people shouldn't be scared to transition to VATS surgery because of a bleeding issue, because I think the issue doesn't really change whether you're open or you're VATS. You just need to be a careful surgeon. And there's a really nice manuscript that the WashU people just published talking about conversions, and as they progress through their training program and acquiring all the new VATS experience, the more experienced the VATS surgeon, the less they had emergent conversions. And I think the culture of making it not a failure if you convert is a very safe culture.
That's good judgment. Sometimes
Yeah.
it's good.
Right.
And early on in your
Yeah.
experience, you should pack, control, and then convert. But later, you should pack, work somewhere else, come back and try to fix it robotically or video assistedly.
But I think that's an important point. I think that converting to open for whatever reason, if disease extent is too much, you've gotten to your limit minimally invasively, or because there is the concern of event, making an open incision is not the end of the world.
No.
And I think people should not see that as a failure. They should see that as an appropriate part of the procedure. I always tell my patients, look, the goal of the procedure is to have a safe and good oncologic procedure at the end, whether that's with small non-rib spreading incisions or a larger incision if it's necessary. It doesn't matter. If we can achieve it with the smaller incisions and get those benefits, great, but that's the third thing on the list.
And I think what you're saying then, to summarize, is bleeding should be managed in a very calm, predictable way, and if you have a method to compress and control, and I think the biggest problem is overreacting quickly, trying to get a clamp in the middle of a bloody artery and making it worse. So the main point is just compress, you know, put your sponge stick in whichever way you like to do it, and then sit tight and figure out how bad is the injury. And as you say, most of them settle out and disappear over a short period of time. And then the other issue is not for somebody who's trying to go from open to minimally invasive to see an open incision as a problem. That's the natural progression in how you get from point A to point B. And if you think, I've got to get through the whole operation the first time minimally invasively, you're going to just defeat the purpose.
And set a time limit. The only thing I would add to what you said is a time limit for you and that patient. It may be 3.5, 4 hours. If you're struggling robotically to do a lobe and you're at 4 hours, it's bad for patient, bad for your reputation, it's bad for the nurses, bad for anesthesia. It ain't good for anybody.
Right.
Just said, at that point, we're going to open because we're not progressing. And that's good judgment.
Right.
It's bad judgment to be in there 6 hours doing
Right.
a robotic lobe or a VATS lobe.
Right.
So.
Right. I think those are all good points. What about the redo situation? Any thoughts, Shanda, on how you manage those?
I actually think VATS is easier than open for a redo. The visualization is better. I'm less often finding myself in the extrathoracic plane. I'm at where I need to be. I don't think always radiation is a contraindication to doing VATS. I think the more you do, the more comfortable you get. And if you're very good at predicting the anatomy, it may not always be the same. You'll find anatomic variations, but if you systematically go about doing the case the same way every time, it's easy to pick those up. And a redo, I don't think is an exclusion.
Definitely not. And I think actually a specific example is someone who's had a coronary artery bypass grafting, a left upper lobe. We presented a little poster on that. But that's a real advantage, I'll say, to the robot, but to also VATS. You can zoom your camera in there, you can see better, you can just dissect right off the clips off the mammary, get the whole lung off. You don't have to leave a sliver of lung on. And so I think redos are actually an indication to do minimally invasive surgery.
But you can leave a sliver of lung on. I
You-
think that's
you
a
can.
very safe approach if
You
you have
can,
a patent mammary.
but
I don't want
you-
people to be dissecting down to the clips.
So if you look at our paper, we only had 2 people. We had 68 or whatever the number, I forget. Almost everybody, you can take it all the way off very easily. When it's open, it's harder because
Yeah.
I do a posterior lateral thoracotomy, and that's very anterior. It's harder to see. I think the robot or VATS offers you an advantage in that situation.
Yeah, I think, I mean, I've had a case where a right lower lobe patient had a metastatic tumor, had ablation, failed, had radiation, failed. So then you've got all that inflammatory change right around the hyaline, but the robot made it extremely easy to take. You can see right down to the microscopic level. You can peel that off. It's relatively traumatic in terms of bleeding, so you don't. Because I think with VATS and robot, what's the major problem? It's when you get that bleeding, that oozing, then you lose your visual advantage. Particularly robot 3D. If you get a lot of oozing, because you don't use a lot of energy, you're pushing a lot and just ripping a lot of tissue. It's not life-threatening bleeding, but then it's just blood pooled in that area you can't see. So for me, robot is great because I can use precision cautery, I can keep it dry, get into that plane, I can see it right there, and allow me to do that case extremely safely. I think for redos, it's great. You know, minimally invasive technology, particularly robotic, is great because you can really discern that correct plane and have it be relatively bloodless. You're not just ripping the lung off the chest wall and get a lot of bleeding and things like that.
The hardest part's getting in. You got to get in and
Yeah.
find a plane. Usually anterior medially is a nice place to get in. Get your finger sweeping in, insufflate CO2 if you want, and then once you get started, it's good. But getting in can be a pain in the neck.
I think the other advantage of whether it's robot or VATS is if you're dissecting a patent mammary or if you're doing a redo situation, you've got everything projected up in the room, and so anesthesia can be engaged, your team can be engaged. Everyone's kind of on an equal level platform, as opposed to when I was a resident training and you're like fighting your attending head, with their headlight, and you can barely get a view in to see what's going on. I think our residents get a better education, which isn't the most important thing. The patient's the most important thing, but it sure is important that our residents learn.
Yep.
So I think
You
it's great
engage
that
the
everyone can
nurses.
see
The
it.
nurses are less bored. I mean, when you do an
Right.
open case, they look at the back of my ugly head. And when you're doing it robotically or VATS, they see it and they're more engaged. So I think you're right.
Yeah.
Now, I think the other point to discuss, and I think, sir, if you may have brought it up, is or maybe it was you, Shanda, is what's more flexible approach? I mean, if we're going to compare robotics to VATS, and I would argue that VATS is a more flexible approach, and I'd like to hear your thoughts on that. But if you run into an unanticipated situation, or the lesion isn't quite, what you thought it was, and you need a different kind of exposure approach. It seems to me that with VATS, you can move around more easily. You can change where the camera is more easily. You can move it back or in front. You can add a port. You can palpate. And I find that those things are very helpful. And I know there are ways to kind of compensate using a robot with your eyes, but I still wonder if it's as flexible an approach.
So I, of course, am going to disagree, except for palpation. I think the palpation point of a nodule, we have to do tattoos because you can't really palpate. Soon, of course, all that's going to be generated with 3D imaging and other ways to find it. But I think you can make ports wherever you want, put the camera in different parts. With the XI robot, you can camera hop. So I don't think that that's true anymore. In fact, I would argue the robot allows me to be more flexible because I can move the lung around, but palpation is different. So there's times I have to make a little incision to put my finger in and say, that 8mm nodule's right there and I couldn't see it and I'm going to wedge it out. And that's where VATS has an advantage, in my opinion.
But how easy is it to move the camera around? I mean, don't you have to take when we've done it, you have to pull the arm out and then move to another arm?
But with the XI, you can put the camera in all 4 arms. So with the SI, you can put the camera in, if you're using a 12mm camera, you can move it to a different port. You can go to the access port, you can keep it in the camera port.
It takes time to do that.
Yeah, well, if your team is good, it takes 30 seconds. I mean, for us, the dock takes, probably takes you 30 seconds to a minute to dock 4 arms. It doesn't take long. When you're first doing it, it takes you 15 minutes to dock.
Oh, maybe longer.
If it takes more than 15 minutes, there's a little bit of a problem. But with the XI, the docking's much easier because it's a much simpler system. The SI, the docking is a bit cumbersome.
Do you have
It's
any
all
thoughts
experience.
on the flexibility, unanticipated issues? What's easier to use?
I mean, I think you also have to remember, when I create my incisions, for instance, I use the robotic camera, but as a handheld thing. So I make my incisions, then you dock the robot. Absolutely, with the older generation robots, once you're docked, you can't just move the camera to a different port. And particularly, let's say you're doing a right-sided case, and it's a redo, and the middle lobe is stuck anteriorly. It's the way I fashion my incisions. It's very tough to take down the anterior-most adhesions. So often, what I'll do is I'll just free hold the robotic camera, and that's basically VATS non-robotic, right? I'm using the robotic camera, but I'm holding it, and I'm using VATS instruments to take down get that middle lobe freed up before I dock. I think with the XI, we're going to solve a lot of those issues, but I do think if you mean by flexibility, being able to switch which instruments you use and your view, absolutely VATS is a little bit more flexible in that regard. But I think probably 95% of our cases we plan out pretty well, other than unanticipated, hey, we're aiming for the anterior mediastinum, or we're aiming for the esophageal mobilization, and so it's not as much of an issue. But I agree with you that for those unanticipated cases, the redos you weren't really adhesions that you weren't expecting, definitely there's some greater flexibility of the non-robotic approach. But I think the technological changes are going to neutralize that somewhat.
And let me ask one last question before we run out of time, which is worst nightmare case, worst type of patient, size, any other considerations where you say, geez, either VATS or robotics, this is going to be an unpleasant morning or afternoon.
So we've argued about this before, but I think an extremely large patient can be challenging with a robotic case. And I think sometimes passing needles in a robotic case can be occasionally somewhat difficult.
Aren't you putting your needles through the trocar?
Yes, yes.
So I actually think really, really fat people is really hard open and VATS. But really, really fat people, yeah, it's hard with the robot, but the robot makes it easier. But you need long trocars. You just pass the needle through
You
the
need
trocars.
long trocars, and you also need to
space is
have
less.
right,
Yeah,
and you
so-
need to have the ability to judge when you're moving that trocar out of the chest. I've had multiple cases where I inadvertently removed the trocar from the middle between the ribs, and it went into the chest wall, and then we had to recannulate, redock, and get it back in. And
So
that
I-
doesn't
Other
happen
than
with
Other
that.
than size, radiation, TB, any other unusual
Well,
inflammatory
yeah, I
conditions,
mean-
IPF, you know, inflammatory lung disease, anything where you say, I don't really want to be here through a minimally invasive scenario.
For me, it's pulmonary artery involvement, and I know there's some people now doing robotic and VATS, pulmonary arterioplasties. But to me, I'm doing all my sleeves now robotically, so that's no longer a contraindication. But double sleeves, I feel like I'd rather have a little incision and have control of the PA. So for me, pulmonary artery involvement is I'll say a relative contraindication to minimally invasive platform. But I understand some people have pushed that limit as well.
Yeah. But on your end?
Yeah, I would agree. Although I think, again, my technique, if I wanted to transition to arterial sleeve resections, using a utility incision, I could probably do that. But I think I agree with Rob that difficult N1 disease, where the chance for vascular injury is much higher, is a case where I'm not, even with the robot, I'm not as comfortable. You know, those are the cases where, you know, I have a lower threshold for conversion. I just think that your chance for some kind of, you know, misadventure with bleeding is a little higher. Everything else, I think I'm pretty comfortable either technique.
And any thoughts on that one?
Yeah, I'd probably say the same. Decortication, sometimes I prefer open. I think doing that in a minimally invasive way can be a huge waste of time. So I think there are certainly some cases where I think you do
Sure.
a much better job by opening.
Yeah.
Totally agree with decortication.
Yes.
Empyectomy, VATS, no robot. Decortication, VATS, and if you can't open, no robot.
I think I think unless you're learning how to dock and acquiring the new robotic technology,
different.
a wedge,
Yeah.
no robot.
I agree.
No, I agree. I think for very simple cases like a uncomplicated wedge, sympathectomy, there is no role for putting the robot in every minimally invasive case. It doesn't make any sense. It's not.
Unless you're trying to pick a very simple, straightforward case to train
for
with,
training.
and the patient understands.
Sure.
But that should be limited because of the
Right.
cost to
Exactly.
5 or 6 cases.
So I think we've come to the end of our afternoon session. We're very appreciative of the audience watching us, and we're very thankful for the chance to talk to you today about minimally invasive lung surgery and look at the advantages and disadvantages of the various techniques, robotics and video assisted. So thank you for your attention. Thanks to the panel
Thank
for
you.
being here.
Good job.
Great, good discussion.